Hello and welcome to our Environments of Practice presentation. We'll be presenting on the area of hospice care, and our group consists of Sophie Grossman, Lisa Johnson, Julia Tessa, Sophie Weber, and myself, Grace Denfeld. So an introduction to hospice is that it refers to the care that is provided to clients who have an estimated life expectancy of 6 months or less, and this is determined by their physician. The goal of this type of care is to improve the quality of life of the client and maintain their comfort during this time. Hospice settings also offer bereavement services, so counseling and other programs to the loved ones of the client after they have passed. We do want to be respectful of anyone who has had to go through this process in recent times, so just be mindful of you and your needs as you're watching this presentation. Some history on hospice is that it emerged as a practice area in Europe in the early 20th century when Cecily Saunders, a nurse from London, noticed that even though medicine was advancing, people were still suffering and dying alone. So she set up St. Christopher's Hospice in London. So hospice is a type of end-of-life care along with palliative care that makes up the end of the continuum of care. So the model on the left is from the World Health Organization, and it shows these two care services together. Palliative care is different because it can occur while curative care is still being provided. So treatments that aim to rehabilitate or cure the patient. As you can see, hospice care occurs before bereavement, but for families shown at the bottom of the model, bereavement is part of this continuum. And we also want to acknowledge at this time the clinician who gave their perspective for this project. So Eliza Sadinki is an OTRL here at Jefferson. She is an advanced clinician and she oversees OT for oncology, bone marrow transplant, kidney and liver transplant, and 2 general med-surg units. And so she would see patients starting in that gray area, the continuum of care, which can be shown through the star that's going to pop up on the slide. And then she may work with them throughout their transition to hospice care. So where does hospice care happen? There are generally 4 levels of hospice care, and they correspond to what the patient needs, as well as the physical location of where the services are provided. There are some differences, which are shown in those titles or labels in the parentheses, but generally these are the accepted ideas. So routine hospice care or basic home care happens in the home, and it is when intermittent services come, such as nursing, home OT, and home PT, to again work on pain management, symptom management, and overall comfort. Continuous home care is when nursing in particular is there 24 hours a day or as little as 8 hours a day. And hospice aides may come as well to attend to the terminally ill client. 3 and 4 is when there's some discrepancy, and that just may be due to state measures or Medicare regulations. So for some patients, they may move on to inpatient care where their symptoms are too severe to be managed at home and they're moved to an inpatient facility. Or they may move on to respite care, which just refers to the time where the family caregivers or loved ones are no longer the primary caregiver and medical professionals are stepping in. Throughout this time, services that refer to home care may be provided at a medical facility where the patient is residing, including a skilled nursing facility. So lastly, in this sort of introductory area, the client population that often receives hospice care is listed here. A very common diagnosis that receives hospice care is cancer, which is seen on the left, which is again why Eliza provided such wonderful insight and why we really valued her opinion, even though she was very transparent that she's not a hospice OT. Other conditions are listed there, as well as notable conditions are ALS or Lou Gehrig's disease, liver disease, HIV, and a general failure to thrive in terms of your medical state. Demographic information on this population includes age, so over 62% are 75 years old, which means there is a significant number of hospice patients who are young. 82 are Caucasian, which may have some things to do with some systemic biases and issues and racism in healthcare and access to these services. The median length of stay for these clients in 2018, when this data was gathered, was 18 days. But the average lifetime length of stay, which is listed on the last bullet, it was 89.6 days. So getting to hospice care is a decision that the patient and family makes together, and it's supported by their care team. So again, the physician must sign off on that 6-month life expectancy in order to qualify for hospice services. And if that person is coming from a hospital, such as the one Eliza works in, they will be handled, or that transition will be handled by a social worker who will coordinate with either a home hospice agency to provide those basic care services, or the transition to an inpatient hospice facility, depending on one of those 4 levels that we talked about earlier. And this decision can be made prior to the later end of that transition and documented with an advanced care directive. So this is an example of an advanced healthcare directive. This is the one used for the state of Pennsylvania. And this is basically a form that's used where clients can fill out their wishes for once they can no longer advocate for themselves or once they have passed, and they assign a medical decision maker. The form for that is in the middle of the slide. And that person is in charge with ensuring that these wishes are carried out. And this person is made known to the physician prior to the client passing. On the far right, you can see some of the decisions that might be made, such as organ donation, autopsy, and burial preferences.
I'm going to talk a little bit about the people who are working there and how they're structured. So talking about Jefferson, they have their oncology floor itself that not only deals with end-of-life care, but deals with everyone who's in oncology. And then when end-of-life care comes to be, there's a palliative care team that's associated with the hospital, but not necessarily part of the oncology team. And they're the folks who come in with expertise about that end-of-life care. And it's usually nurses and physicians, and they would be the ones who would provide expertise on what people need for that palliative care, run goals of care meetings with the family members, and generally guide that process, both for the person's regular doctors and for the family members. Another component that's outside of the traditional oncology floor are social workers and case managers. So those would be the folks who would coordinate referrals, especially if someone needs to go to outside of hospice in the hospital, would no longer qualify for that. And then speaking of that, there's outside organizations that would handle home hospice. So if someone does not need inpatient care, they would be transferred to home hospice. And they are separate organizations that would really take the ball running. But one of the ways that the OTs on the oncology unit interact with them is making recommendations for equipment purchasing to make sure that that person has what they need at home. So within that, the role of the OT is really to work with a palliative care team, to work with the doctors, and to provide rehab as well as rehab assessments. A lot, especially around end of life, a lot around positioning and things like that. They also contribute to decision making. So for example, if a patient seems to be in a lot of pain and really doesn't want to be doing therapy every time we come in, we can talk to the palliative care team, and that's useful information for them to share with the family members to make good decisions about what's best for the patient. Our typical productivity, or their typical productivity expectations, is about 50 to 60% a day, in large part because they're dealing with very complex patients, and they see about 7 to 9 patients a day. For supervisors, that's actually less. It's about 3 to 4 to accommodate for those supervision duties. Overall, it seems like they've kind of got a program structure. So levels of management, there's a supervisor for rehab on a certain floor, and that person manages all of the rehab professionals on that floor. Above that are managers. There's 3 clinical team leaders. And then above that are both a program manager and associate administrator. So the associate administrator would handle more of the business components of things, where the program manager would handle more of the program aspects of things. In terms of how they work with other team members on the floor, the OTs and the rehab, nursing has a whole different structure with its own management up to a certain point. But they collaborate together a lot, and they'll all go on rounds together. So nurses, pharmacy, physicians, rehab, including OT and PT. A lot of the challenges they talked about related to service delivery and management are pretty typical ones. Medicare rules can be complex, and lack of insurance can be complex, especially in terms of admitting people to the hospital. If someone doesn't have insurance or Medicare doesn't qualify, they have to do kind of these weird processes where they basically admit them, but they can't call it admission. Productivity management is always a hot button issue. And then COVID, of course, even in terms of transporting the patients, are all things that this administration and this structure has to deal with.
There are 3 main bodies that are used for accreditation of both home health and inpatient hospice care facilities. The JCAHO, or the Joint Commission, is the body used for nursing care, home care, and hospitals nationally. This particular organization is the accrediting body for Jefferson Hospital. The Accreditation Commission for Healthcare is often utilized for the accreditation of Medicare certified hospice settings. Finally, the Community Health Accreditation Program is specific to home and community-based care. Different organizations will often be used for the accreditation of different settings, and the differentiation of home care versus inpatient care should be acknowledged in this process, as different processes may be required. When a loved one is terminally ill, family members will feel sadness, fear, anxiety, and stress. If a patient cannot speak up to make decisions for themselves, family members or a proxy will make decisions on behalf of their loved one, and this may be triggering and difficult. If they do not know their loved one's preferences regarding end-of-life care, they cannot be sure about whether they can make the most appropriate decisions for a patient, and they may not understand the full extent of their loved one's abilities. Many family members will want to do everything in their power to keep their loved one alive, even if those decisions are not healthy for the patient. This may lead to discrepancies in treatment, and difficult conversations will need to be had with family members to discuss the reality of the patient's abilities. If a patient will not realistically make any functional improvements, practitioners will have to remain sensitive, empathetic, and objective when having these conversations, especially if their suggestions go against the family's wishes. A palliative care team may be brought in for assistance. It is important to ask, is this what the patient wants? Although family may want a certain course of treatment for a loved one, the patient may want the opposite. A patient may not want to be rehabilitated when their family is pushing for it. Additionally, a patient may seek just comfort and stability in a hospice setting, and they may not have strength for intensive rehabilitation in their condition. Dilemmas may occur in these situations, especially if a patient cannot speak to what they prefer. Family members may make decisions that aren't the best for their loved ones, and the line between doing what's best for the patient and acknowledging the family's or proxy's wishes may become blurred. The practitioner should use the principle of fidelity, and as they continue to advocate for the best care for the individual, while being open and honest with the patient's family about the extent of their condition. Research has expressed another significant ethical dilemma. For some, certain treatments can be life-saving and effective, while for others, treatments can be very risky and worsen their quality of life. Some controversial treatment methods include CPR, parenteral nutrition, and terminal sedation. A patient may or may not wish to receive these treatments as their condition worsens. Deciding whether or not to administer certain interventions may be a difficult decision made by physicians or family members, and physicians may think that the decisions made by the family members are not the most appropriate for the patient. A competent patient may not want to undergo certain interventions as they deteriorate, and this decision is called a DNR decision. Despite these requests, the patient's family members may ask the physician to perform the interventions. In this case, if the patient is conscious and has the ability to make decisions, the patient's choice is taken into account. If not, ethical dilemmas may occur, as the family's wishes may not align with the patient's. Finally, the presence of COVID-19 has also impacted ethical caregiving. COVID policies have impacted the extent to which compromised individuals can seek out care, and lack of access to needed treatment may occur. For example, a patient in a rehabilitation setting who needs to seek out chemotherapy for their cancer may be forced to prioritize which care is most important. As some settings have created COVID-related policies which prevent residents or patients from leaving the facility and later returning, this patient may be forced to choose rehab or chemotherapy, as policies will not allow for them to access both. The autonomy in making decisions surrounding care access is therefore taken away from the patients who desperately need treatment in multiple settings. Ethically, this does not allow for best practice, and it decreases a patient's autonomy and self-determination in the course of their condition. Overall, it is important that practitioners remain vigilant in encouraging the best care for their clients. Autonomy is a patient's right, and maintaining self-determination and dignity at the end of a patient's life should be the practitioner's priority. The help of a palliative care team can help to avoid these ethical dilemmas in practice, and they will greatly benefit patients, families, and practitioners.
It's important to understand funding, as we are all occupational therapists who want to be reimbursed for our time. Reimbursement is provided through a variety of medical insurers, such as Medicare, Medicaid, and private insurers. Funding can also be acquired through hospice organizations that may receive grants and private donations. Oftentimes, local civic, charitable, or religious organizations may provide financial support to families and those who are undergoing these hospice services. Within the specific hospice hospital setting, we discussed this with Eliza. Within hospital setting reimbursement, we discussed with Eliza how OTs become reimbursed. OT services are included in the total cost of hospital stay, so the hospital is reimbursed, not the specific practitioner. It's important for us as occupational therapists to understand and be aware of the policy and legislation in place within this setting. Recently, due to COVID-19, the Centers for Medicare and Medicaid Services temporarily suspended regulatory requirements, now allowing occupational therapists to open Medicare home health cases. This was passed on April 9, 2020, but currently Medicare Home Health Flexibility Act is in discussion, which would allow this change to become permanent. We can all advocate for this act by clicking this link. It sends letters to and emails to your representatives and your senators. I sent them in for both Pennsylvania and New Jersey, so however many addresses you have, advocate as much as you can. We also discussed with Eliza her input on what changes in policy may be necessary in this setting. She spoke about the different challenges in the hospital setting, specifically the difficulty in using Medicare. If a patient were to come into the hospital but does not meet hospital's criteria for admission, they gain an observation status. This observation status limits what occupational therapy care is available for them, including what care can be recommended and given, such as a recommendation for discharge. A cause for this is that diagnoses are often generalized. For example, a broken arm is not considered a diagnosis requiring an admission, and unique client circumstances are often not taken into consideration. Another challenge that Eliza mentioned is the lack of rehab program qualification when necessary for clients. Eliza also discussed with us the impact of COVID-19 within this setting. She explained the need for adjustments in current COVID-19 transportation regulations. At the current moment, patients cannot leave the hospital and return. For example, as Sophie had previously mentioned, this could impact patients traveling back and forth from chemo to rehab. Overall, in this setting, we need policies to be adjusted to ensure that all clients have access to hospice care.
Looking towards the future, there are many possible directions for occupational therapy practice in hospice care to grow. Under the broad umbrella of education, there are a huge number of research questions that haven't yet been thoroughly studied. As well as developing the overall evidence base, a push towards further research will also help put palliative OT services on the map, since students and other medical professionals in many programs don't have a clear understanding of the value that OT can provide in hospice care. Eva and Morgan, in their 2018 paper, write that survey results showed a marked contrast in time allocated to patient care versus research and service development, indicating that research is not a current priority in terms of time allocation for hospice occupational therapists. Changing productivity requirements and building in more time and funding for research to be performed will help to amplify the role of and boost evidence for hospice OT. In terms of furthering the scope of OT services in hospice care, two key areas that we identified from our research are those of building further services and of educating patients about existing services that are available to them. An example that Eliza mentioned is that sometimes family members aren't sure whether rehab or hospice is a better option for their loved one. That's just one of the many kinds of decisions that a palliative care OT can assist with. Further services might also include more work with patient families, more time to focus on truly valued occupations for patients instead of having to allocate the bulk of a patient setting for ADLs, or even branching into new areas such as group therapies for hospice patients. In order for all patients to be able to access services, it's key that insurance companies cover them and that other medical providers like ICU clinicians, oncologists, skilled nursing facility practitioners, et cetera, also acknowledge OT's value in end-of-life care. This will require specific, concrete conversations with families before it's time about the benefits that OT services might have for a patient, as well as targeted outreach to healthcare workers who are in positions to pass this information on. And of course, legislative changes that encourage insurance companies to ensure as much broad coverage for possible for as many people as possible. As is often the case, OT is in a position to uniquely assist people in all stages of life. The piece that needs work is expanding access to those services. And here are some key journals that we used. So the Journal of Hospice and Palliative Nursing, and also the Journal of Palliative Medicine, which is published in Europe. Both great resources. And here are our critical references, followed by our full reference list. Thank you for listening to our presentation.